Good morning, everyone, dear committee, dear audience. It's my great pleasure to introduce my first PhD student in this program, and as Peter mentioned that in 2019, when we moved from Page to the Semmelweis University, this gentleman approached me that he wants to be my PhD student. He was the first to approach me. Now he's the first who will present his work. So Caner was born and raised in Turkey, and after graduation he was expelled from Turkey and came to Semmelweis University and finished and graduated here in 2019. And then because of the COVID, he went back to Turkey and did some work there, and when the borders opened up again, he returned, and that was the time when he approached me to take part in the Translational Medicine program. And as I mentioned, he was one of the 6 who we formed basically the critical care group here at Semmelweis University. I wait till you take the QR code. And if you have to grade my introduction, please use the best marks, because otherwise Peter won't let me continue my work here. So getting back to Caner's work, and after the first year, which was an excellent experience for all of us, he decided to stay within the domains of translational medicine, and he became a senior methodological supervisor, an SMS, in translational medicine. But also, out of the 6 students, 3 together with Caner started their residency at the Department of Anesthesia and Intensive Care. So they did both at the same time, as it is nicely structured here in the Translational Medicine Department. So after year 2, he became an SMS, and we've been working together ever since, and he's leading the critical care group. And this year, so September 2024, we formed our first own critical care group with 9 students, and Caner is not just the senior methodological supervisor of that group, but he is also leading it from the conceptual point of view, basically taking over our job almost completely. So I'm indebted to Caner because his contribution to the group is beyond measure. And in addition to the scientific work, which is really his elements, by the way, presenting and asking questions, debating, he's a very well-educated gentleman. He likes to read, he loves history and politics, and he loves to debate, and what he loves most is talking. So with this, I would like to hand over to him and let him do what he loves best, talking. So ladies and gentlemen, it's my great pleasure to announce Caner Turan.
Only 20? Good morning, everyone. It's my pleasure to be here. Dear committee, dear audience, I'm going to present my 2 projects today that are related to my PhD thesis, which is the perioperative management and critical care for patients with liver dysfunction. After Jolt's introduction, I will only briefly introduce myself again. My name is Caner Turan, and I'm a resident at the Department of Anesthesia and Intensive Therapy in this university. I started my PhD with a vision to be among the new generation of scientist physicians. And my mission to achieve this is to replace tradition and habit in the clinics with scientific thinking. As anesthesia and intensive therapy are a joint science, we conducted 2 studies, one is about anesthesia and the other is about critical care. We believe in evidence-based medicine. What does this mean? This means the patient is the first and foremost what we need to deal with. When we are treating or looking at our patients, we have to formulate research questions all the time. And we have to do research and trials to try to answer our questions. Once we have original research, we can move on to systematic reviews to summarize and contextualize what we have learned about these patients and these questions. And then we need to translate what we have found into policy and protocol. and then we have to see if these policies and protocols work, and we have to repeat the cycle. So what we were dealing with is, in the first round, do recommendations of a protocolized guideline work in real life? And then we looked at original research and asked, how do we optimize and protocolize a novel intervention? But finally, the overarching theme of this PhD work was, how should we approach high-risk patients with a poorly understood condition? The poorly understood condition I'm talking about is liver dysfunction. Now, we all know medications, organ failure, surgery, and infection can have significant effects on how the liver is working. But what is not really understood clearly is what happens to medications, to inflammation, to shock, when the liver has already dysfunctioned. So our first project is about the anesthesia, the effect of preoperative administration of glucocorticoids on the postoperative complication rate in liver surgery. So liver surgery, despite recent advancements, is still quite dangerous for the patients, with mortality rates reaching up to 20% and almost half of the patients undergoing liver surgery experiencing some sort of postoperative complication. The cause behind it is thought to be operative stress or injury to liver parenchyma, but also one hypothesis is the dysregulated immune response, which leads to systemic problems. So what can be a solution for this situation? We hypothesized that immune modulation using steroids could be one answer. Why did we conduct this study? In the 2016 Enhanced Recovery After Surgery guidelines, the preoperative administration of glucocorticoids were recommended with a weak recommendation using moderate level of evidence. These guidelines were taking two meta-analyses from 2014 and 2015 as a source. Since then, two more meta-analyses came out, one reporting a non-significant effect of glucocorticoids, but the most recent one reporting a significant effect. But since the 2021 paper, 4 new randomized controlled trials were published with 400 more patients, almost doubling the number of patients enrolled into these studies. So how we did this? Our research was framed around a PICO framework. We asked if preoperative glucocorticoid administration is safe and effective in reducing postoperative complication rates. Our aim was to reproduce guideline-informing research in the light of these new evidence. We conducted our systematic search in 3 databases, and out of 9,000 records, we have found 11 randomized controlled trials to be eligible for this study. Our main outcome was the overall postoperative complication rate, for which 9 out of 11 papers reported. And what we have found is a non-significant tendency to have a lower odds of postoperative complications in the intervention group. We then looked at particular complications, not only overall, and we have investigated septic or infectious complications, pleural effusion, bile leakage, and liver failure, all of which are common postoperative complication rates reported. However, when looking at particular outcomes, we did not see any signal or any tendency that convinces us that the intervention is better than the control, except for one particular complication, which is the wound infection. So in the wound infection following liver surgeries, we actually found a significant result favoring the glucocorticoid administrations. However, as we also discussed in our paper, we should take this result with a grain of salt. We suspect that there might be measurement or reporting biases from the included articles. There were high in-study and between-study heterogeneity, and the quality of evidence that was reported by the randomized controlled trials, which theoretically should be the gold standard of medical research, were quite poor. We also looked at safety outcomes, such as length of hospital stay, total operative time, blood loss, and the number of patients needing blood transfusions. In safety outcomes, we haven't seen any signal that would lead us to believe that the intervention was more effective than the control. We also aimed to look at laboratory outcomes following liver surgery, whether to see if there is a difference between intervention and control groups. However, because of the very poor reporting of data, we were unable to meta-analyze this, so therefore we discussed and summarized these results in the systematic review part of our papers. And as you can see, in total bilirubin levels and IL-6 levels, there was indeed a signal that's leading us to believe that the intervention was more effective than the control, but without properly designed randomized controlled trials, it is very difficult to conclude. We also assessed the quality of evidence and risk of bias in the included papers, and the risk of bias was moderate, despite the fact that they are all randomized controlled trials, and the level of evidence that we could gather from our included papers was very low for our main outcome and low for all of our secondary outcomes. In conclusion, we can say that preoperative glucocorticoid administration does not reduce overall complication rate significantly. Except for wound infection rate, there are no statistically significant differences between particular complications or in perioperative safety outcomes. And finally, level of currently available evidence is insufficient to draw any conclusions regarding the use of glucocorticoids in liver surgery. In summary, we had some strengths and limitations of these papers. We only included randomized controlled trials. We, to our best of our knowledge, we have the largest patient pool to date on this subject. We analyzed the most broad range of outcomes, and our study was fully compliant with international standards for quality and systematic reviews. Our paper had some limitations as well, such as we could not perform subgroup analyses due to poor data availability, and we could not perform meta-analysis on part of our secondary outcomes due to poor data availability. The implication for practice is that recently made recommendations by reviewers and trialists advocating for the use of glucocorticoids must be reconsidered in the light of this new evidence. And the implication for research is that this intervention remains an important field of research, considering the high risk of liver surgery and the conflicting results in the literature. It's clear that future studies should be designed especially to generate better clinical evidence. Our second project is from the intensive care domain, hemadsorption therapy for critically ill patients with acute liver dysfunction. Critically ill patients may acutely develop liver dysfunction. This is different to chronic liver failure, and this is a deadly situation where around 60% of critically ill patients will develop this, and the mortality rate can reach up to 86%. We have some treatment options in the ICU, such as managing the complications, bridging patients to liver transplantation, or using life support. But there is a novel strategy called hemadsorption therapy, which approaches this situation from multiple angles. It is a cytokine absorber. It absorbs inflammatory mediators, helping the hyperinflammatory condition, reduces bilirubin and other potentially toxic molecules, and it might lead to improvement of liver and kidney functions as well, which may lead us to more successfully bridge our patients to liver transplantation. We also set our study with the PICO framework, where we asked, does hemadsorption therapy effectively reduce the levels of cytokines and liver function-related metabolites in critically ill patients? Here, our primary outcomes were mortality, liver function, and cytokine levels in our patients. Our aim was to summarize and synthesize all currently available evidence on hemadsorption therapy in critical illness-associated acute liver dysfunction in order to formulate hypothesis-generating arguments. We conducted our systematic search in 5 different databases, and out of 3,400 papers, we have found 30 studies to be eligible for meta-analysis. Part of our primary outcome was the post-treatment level of total bilirubin, where we looked at observational studies and we tried to see if there is a difference in the post-treatment levels of bilirubin. And in fact, we have found a clinically and statistically significant benefit to using hemadsorption. Another part of our main outcome was the post-treatment levels of creatinine, but here we did not find any clinically or statistically significant benefit to using hemadsorption therapy. We have also looked at individual patient level data for laboratory outcomes, such as levels of ALT following the treatment, in which we did indeed find a reduction in ALT, but this did not reach statistical or clinical significance. We also looked at AST levels, where we did indeed find a statistically significant reduction in the levels of AST, but we thoroughly discussed whether this is clinically significant or not. We also looked at total bilirubin levels after hemadsorption therapy, and here we found a very strong signal that bilirubin levels are decreasing, but this analysis did not reach statistical significance. We also looked at creatinine levels, similarly to the cohort study meta-analysis, but here we did not find any statistical significance either. We looked at CRP levels, which are all inflammatory markers, and here we found a potentially clinically significant benefit, but it did not reach statistical significance. And finally, we looked at vasopressor need, which is a very important clinical outcome, and here we found both a clinical and statistically significant benefit to using hemoadsorption, meaning that patients who were receiving hemoadsorption therapy were much less likely to need vasopressor support for extended duration of time. In conclusion, hemoadsorption was safe to use, as none of the 30 studies reported any device-related complications. We conclude that the use of hemadsorption yielded a trend toward improved liver function. However, the quality of current clinical literature is insufficient in its precision and its comprehensiveness. Therefore, it is implicated that in cases of acute liver dysfunction in the critically ill patients, the use of hemadsorption therapy is safe and it may improve liver function. And the implication for research is that our results actually open the way and render the need for adequately designed clinical trials with the parameters investigated in the systematic review as main outcomes. And we are excitedly looking at new publications to see if properly designed original research papers are showing any benefit to the hemadsorption therapy. As part of my PhD journey, I was also lucky enough to be involved in many extracurricular, let's say, activities. And one of which is that I was able to, with the support of Semmelweis University, I was able to get my postgraduate diploma from the Harvard Medical School within the framework of the Harvard Medical School Semmelweis University Clinical Research Joint Program. And also, as Zsolt very kindly introduced, I have been a scientific methodology supervisor for almost 3 years now. And this means that I have been overseeing 9 first-year students, 15 second-year students, and 5 third and fourth-year PhD students. And these students are not only from anesthesiology and intensive care domain. In fact, only half of them are from my own domain. And I find this to be a strength of the translational medicine system, because working with many different domains such as pulmonology, gynecology, and cardiology, the free exchange of ideas and free exchange of inspiration was a guide for my scientific career. And I have also been lucky enough to be a co-author in 9 publications that came out within these 3 years. And I'm very happy to say that there are 2 more papers that have been accepted for publication since the preparation of this PPT. I have also been active in national and local conferences, such as SIASTOK, which is the Hungarian Conference of Emergency Medicine, Anesthesiology, and Intensive Care. I've also been active in scientific meetings within the university, such as the PhD Scientific Days and Semmelweis Symposium. I've also been lucky enough to go and present the results of our studies in international conferences, such as the European Society of Intensive Care Medicine in 2022 in Paris, and also in the Czech Republic Colors of Sepsis Congress. And I'd like to close my presentation with the quote that guided me throughout my scientific career, that the difference between screwing around and science is simply writing it down. Thank you very much for your attention.
Thank you very much, Kaner. Just first of all, I'd like to ask the audience if there is any questions. I hope so. There are a lot. Okay, just it's still early in the morning. Then I'd like to ask our committee members, the opponents, first of all. Gabriel, for example, if you have some questions.
Congratulations with this excellent works, and I enjoyed as a hepatologist very much. For the first part, I would like to ask, although I found some answers, that have you made any subgroup analysis for the hepatic resection group and for the liver transplanted group for the effect of steroids? Mm-hmm. Because for me, these are completely two different patient group for the type of post-operation treatment. For example, as we know, after liver transplantation, they will get a big immunosuppressive therapy. Whether we have a liver resection, we don't have this type of treatment. So did you make a subgroup analysis only for the patients with liver resection? Mm-hmm. This is my question for the first time. Why did you follow the bile leakage group? I think it is somehow an operative problem and not a post-operative case of infection or these things. And it was also very interesting that you found that wound infection is decreased after steroid treatment, although we learned that steroid decreases the wound healing. So how can we make connection with these observations? Thank you.
So the first question about subgroup analyses, we did protocolize that we are interested in having a subgroup between those patients who are having liver resections and those who are having liver transplantations. But furthermore, we also aim to see different groups of patients based on the etiology of the liver surgery, what was the reason for the liver surgery, and also the operative risk scores, because not every patient who is undergoing a major hepatic resection is belonging into the same group. We had 11 randomized controlled trials in this study, and 9 of them were reporting solely on major hepatic resection. 2 papers had liver transplant patients in them, and they failed to separate the outcomes that are coming from liver transplantation patients and hepatic resection patients. This is a scientific mistake. We are not agreeing that an original research should be conducted like this. And we discussed at length that for future clinical trials should not be planned as such. Indeed, it's very easy to believe that there will be differences between those patients who are undergoing major hepatic resection and those who are undergoing liver transplantation. So that's why every time we disseminated the results of our studies, we asked very kindly for trialists to separate these patients, because otherwise it's very difficult for an operative team or an anesthesiologist to stratify their patients based on their risk. The second question is about the bile leakage. So in fact, the bile leakage was hypothesized to be one of these complications that steroids could be very helpful. The whole story, the whole narrative about using glucocorticoids, preoperative high-dose glucocorticoids, came from studies conducted by Japanese colleagues in the 1990s. They were using, at first, their clinical observations and animal models and basic scientific literature. And they hypothesized that this should be reflected in a clinical trial as well. And in fact, when the enhanced recovery after surgery protocols were being drafted, some of the original research articles that were used and referred to were the same Japanese papers. So this was a question that operative teams were asking themselves, whether this intervention can actually reduce bile leakage. And this was one of the reasons why we chose to also meta-analyze this outcome and try to see if the hypotheses of our former colleagues were correct. This was the reason. And the third question was about wound infection. So in a pathophysiological way, wound infection, it has very different parts of a complete system working with each other. And there is an interaction between pro-healing factors and, let's say, anti-healing factors. Without rigorous observation from both basic research side and also from clinical trial side, without rigorous investigation and observation of where and at what stage which part of the system is inhibited, which part of the system is promoted, it's very difficult to conclude just from a meta-analysis that this is the reason why it is happening. But from a methodological point of view, and we should keep in mind that the reason why we did this study was not to discover new pathomechanisms, but rather to inform clinical workers and investigators. A meta-analysis is unable to answer this question. We did propose a couple of hypotheses in our published paper, but it is my honest opinion that the methodological answers are probably closer to reality than pathological or pathophysiological answers. I hope this answered your questions.
Okay, so I'm going to go question by question. I'm not going to list all the questions, so it's going to be much harder for you
it's
to...
It's good to challenge my memory.
Let's divide it. Congratulations on your PhD thesis. I'm really happy with everything I read you done, and I think you made a great effort. But as an opponent, I must oppose you, although I'm agreeing with most things you wrote. So you were aware that in liver failure, especially in acute one, we have a couple of different techniques we can use. So what was the case you have choose to write about hemadsorption and not write, for example, about plasma exchange, because we have data, strong studies. Some of them were also RCTs, which show that it can be beneficial. In your thesis, you have listed all the papers you have analyzed, but it's really hard to say were there really acute liver failure patients or acute and chronic liver patients. Can you comment on that?
Yes. So can I have the PPT one more time? So the first question is why hemadsorption and not plasmapheresis or total plasma exchange? Well, the answer is very simple. With plasma exchange and plasmapheresis, we have quite good evidence, both from basic science part and also from clinical studies side. But what we were trying to do is taking a novel intervention that hasn't been thoroughly researched and help future trialists and future clinical investigators have a path to understanding the benefits and potential risks of this intervention. When we are conducting a systematic review and meta-analysis, we have to keep in mind that there is an acronym that is very practical. It's the FINER. Has to be feasible. It has to be interesting, has to be novel, and also ethical and relevant. So here we found that surely both hemadsorption and other blood purification and immune modulatory strategies, meta-analyzing them, yes, it would be feasible. There are many original research papers that are bothering with these questions. Now, the interesting part, we thought that contributing to the scientific literature on a novel intervention is more interesting both for patient benefit and also for clinical practitioners. And there comes the novelty aspect of it. To the best of our knowledge, this is the one and only systematic review and meta-analysis that is summarizing the clinical literature on the use of hemadsorption in critical illness-associated liver dysfunction. And the other question about these 30 papers and all the patients that are collected from these papers, are they acute liver failure or acute on chronic liver failure? Now, we were lucky to protocolize this in a way that we would include both acutely developing liver failure and also acute on chronic liver failure. In some of the papers, we had a combination of acute on chronic liver failure patients and ICU-acquired liver injury patients. But once again, we really don't agree with the idea that trialists have of pooling different patients together without stratification. So doing a meta-analysis would only be possible if we were to approach author by author and asking for further data, more stratified data. Please share with us the patient-level data. But this brings us back to the feasibility, because the time is running out. People are asking this question, and we have an obligation to conduct our study and publish it as soon as possible. In a future study, in my opinion, critical illness associated acute liver failure and acute on chronic liver failure should be taken as two separate entities. That's for sure. But I would also recommend that we have a better understanding and a better discourse surrounding acute on chronic liver failure, because both the definitions and the literature so far is quite contradictory, and we really need to clear things up when it comes to acute on chronic liver failure. And actually, one of my future study plans is exactly about this.
One of the biggest issues, hemadsorption is actually not a novel therapy anymore. It's been there for 15 or 20 years, although we have new and newer cartridges with newer indications as well. And we have clinical evidence, mostly based on clinical case series or clinical case reports, that this therapy can be efficient in various indications. And still we are lacking big RCTs which are confirming that this therapy is effective. And in most cases, the primary outcome was mortality in ICU when they were admitted during 28 days, 30 days, whatever.
Yeah.
What do you think? Do you agree that this is one of the biggest flaws in constructing an RCT regarding the effectiveness of hemadsorption?
It is my honest opinion that in critical care literature, using mortality as an outcome has more problems, more risks than potential benefits. If I were to conduct a surgical or a pharmaceutical study, I might be looking at mortality. But in a critical care situation and in a critical illness situation, actually mortality is not a very hard outcome, because it's confounded by many factors that are known, let's say there are known knowns. There are those variables associated with a critically ill patient that we know is confounding mortality, such as the number of available staff in an ICU. The more staff per patient you have, the lower mortality you can expect. But it's not really believable that trialists will actually stratify their patients and report the number of staff per patient in order for reviewers like us to make a conclusion about that. There are also unknown variables that are confounding mortality in a critical illness situation. Now, possibly one of the most significant factors contributing to mortality in critical illness is the consequences of multi-organ dysfunction. Now, the reason why we call this multi-organ dysfunction is because it's like an Ouroboros. We don't know where it started, where it's ending up, what are the checkpoints, what are the stages, where is the patient clinically at the moment. We have a couple of scoring systems, like SOFA scores, and specifically for liver disease, we have the MELD score and Cliff SOFA score. But even these scoring systems are quite controversial because, yes, they are giving a very quick picture about our patients. We know that if somebody has a SOFA score of 20 and a SOFA score of 5, we can immediately assess the situation and we can go with our gut feeling and say, SOFA score of 20, this patient needs more rigorous interventions. But it fails when we are trying to plan long-term with different therapeutic goals, and we have 2 patients who are both SOFA score 10. Now that's a big question mark, because 2 patients with SOFA score number 10 do not necessarily resemble each other, neither in etiology or disease processes, nor in therapeutic goals. So what I would recommend, and this is one of the reasons why we included vasopressor need following the intervention as one of our outcomes, that in fact in a critical care study, what we are interested in is during the intensive therapy process, because this is a holistic approach that has everything from pharmacotherapy to psychotherapy to physiotherapy. In the intensive therapy process, we would like to see our patients requiring organ support in fewer days. So the fewer organ support days we have, the better. And my honest opinion is that future critical care studies should be focusing on organ support-free days as the main outcome of interest and not mortality. Of course, there are some problems with having organ support-free days as a main outcome of interest in clinical trials, such as it's very difficult to calculate a sample size and statistical power, but in the 21st century, in times of, and we have biostatisticians here as well, in the 21st century, this is not an unsolvable problem. We have both methodological and technological solutions for calculating statistical power using organ support-free days as well. And in fact, one of our conclusions at the end of this paper was also to state that future clinical studies should focus on patient-specific outcomes. So disease process-specific outcomes, not just mortality. Mortality is demographics, it's statistics.
Thank you. Based on your work, I know it's really hard to conclude it after a meta-analysis of very scarce data regarding hemadsorption in liver. But you have an additional big questions regarding when prescribe therapy, when to start with the therapy, how to monitor the effectiveness of therapy, and when to stop the therapy.
Yeah.
You have cleverly described in your PhD thesis the difference between 2 different, I would say, time points of liver injury. Firstly, liver injury as a result of hypoperfusion, which is actually similar to development of AKI. I would like if you can try to extrapolate that. And the second thing is cholestatic liver failure, which is actually caused by the increased level of cytokines.
Yep.
You have a paper by Christina Sharp, who actually is hypothesizing that the molecular size of AST and ALT and GGT is not capable for hemadsorption on different hemadsorbers. And on the other way, you have a bilirubin, which is actually decreasing. So what do you think, what would be the next steps? Because this is my last question. If you are trying to create an RCT, how would you create it? Would you like to first do a registry? And on the results based on the registry, you have some clinical variables on which you can build your RCT. And what would be the monitoring of therapy? Would you like to do it pre and post cartridge?
So I first of all, I have to preface this answer by challenging this idea that randomized controlled trials are the gold standard in clinical science. This is tradition, this is habit. Randomized controlled trials are able to answer some questions brilliantly. but they are not the be-all, end-all golden bullet for every clinical question. Each study methodology has its strengths and its limitations. And given the research question we're trying to answer, we have to choose that study type, which is the most advantageous for answering that research question, over randomized control trials just because they sound fancier. So actually for hemadsorption, in the future studies for hemadsorption, I would start with having an international registry with patients that are enrolled from multiple centers for multiple indications, and I would conduct plenty of frequent interim analyses of this international registry. And what I would try to answer is to correlate between parameters that I'm collecting from patients and the clinical course that these patients are following. If I'm only looking at a registry and seeing that, those patients who are receiving hemoadsorption are still dying at this rate. Okay, this is not interesting. We already know critically ill patients are at a very high risk of mortality. What is very interesting to see now is, as you described, what patients who have what variables, who have what characteristics, who underwent what type of intervention and also co-interventions were more likely to get better sooner. So my first strategy would be to simply collect data with a registry in a systematic way, in a protocolized way. Without data, we cannot make any assumptions. Once we have a registry and we analyze it, and we see some signals that are coming out of the registry that are leading us to believe that some markers of clinical process seem to be more correlated to a better clinical course, then we have our investigation.
You have questions? Just during your thinking, you mentioned that we have to choose the right data or the right
Study type.
study to monitor the progress of the patient and a clinical course. And my question would be exactly on that topic, that you picked creatinine to assess the kidney function and it's not about methodology of this type of studies, and it's not about meta-analysis, and I don't want to limit the importance of meta-analysis. I think it's very, very important and useful. But especially creatinine.
Mm-hmm.
Creatinine is already demonstrated as a non-specific, not sensible marker of renal function. From these data that you have demonstrated, I could not even justify whether they are clinically or preclinically in renal failure, because I haven't seen the data of the serum creatinine levels. So that means that there was no difference between prior and after the intervention, but we do not even know whether the creatinine was high enough to say that there is a renal injury.
Yes.
Not to mention that creatinine is absolutely nothing for that. What do you think about this?
I think this is a very, very important point, and it's good that the audience has a lot of PhD students who's going to be here answering these types of questions in a couple of years, because this is really a learning moment. Now, when we are conducting such a systematic review and meta-analysis, the strategy underlying this methodology is a little bit different than original research papers. Now, if I were to be conducting an original research about the use of hemadsorption, first and foremost, I would make it clear whether these patients actually have acute kidney injury or chronic kidney disease, or what is the kidney status, which the pooled studies, the eligible studies, failed to do so, which is one of the biggest mistakes in hemadsorption-related literature. In fact, creatinine is, even for screening already admitted into intensive care patients, even screening them using creatinine has a lot of question marks. We are not really sure whether creatinine or how much creatinine correlates to the disease process. We know that extreme levels of creatinine will give us an idea that possibly there is something wrong with the kidney, but the kinetics of creatinine is possibly much more interesting than the raw absolute data of, you know, what is as a cross-section, what is the creatinine of this patient at this moment. That's possibly much more interesting. But in this literature, this is what they are reporting. So what is the creatinine level at the moment of post-intervention 3 days? What is the creatinine there? Okay, but we are really interested in how the creatinine is moving. That's much more interesting. Now, the reason why I brought up this as a learning example is because when we are writing a systematic review, we have to anticipate the kinds of questions that our audience are asking. And since creatinine was one of the most frequently reported outcomes for hemadsorption studies, it's safe to assume that actually people are wondering about creatinine levels after hemadsorption therapy. And if you're having a patient in the clinic and you're wondering how creatinine is going to be affected, now you don't have to read 30 articles out of 3,500 potentially interesting papers. Now we have very neatly, very systematically summarized, listen guys, this is what we know about creatinine. Please, rather than using these kind of laboratory markers, instead look at disease-specific processes, patient-level outcomes, and not just creatinine.
Yeah, I think this is the main point, and unfortunately I'm a nephrologist, but I don't want to go into debate with you right now about the about the creatinine levels. But I think this is the main point that that has to be emphasized. That with this conclusion you made, it does not mean that hemoabsorption might not affect, for example, kidney function. It does not have any effect on creatinine levels. So it's two different things. Mm-hmm. And I would be really cautious about have suggestions about on the importance of this method on kidney function, because the market itself, it's not that optimal. So yeah. I got the point that you have to somehow to solve the readers, to solve the doctors, to solve everybody. But on the other hand, we have also a scientific and also clinical responsibilities.
Yes. So we really made sure to be very, very conservative when we were drawing conclusions, especially given the fact that a meta-analysis is only as strong as the eligible articles. So if our meta-analyzed articles have methodological or clinical gaps in its quality, then the resulting meta-analysis will also inherit such low quality. And that's why we are never on the side of making big assumptions, big jumps. Yes, this therapy has to work because look at the creatinine. No,
yeah,
that was not our approach.
I think it's a very modest, a very wise opinion of yours as a meta-analyst, and congratulations on that conclusion. I do think that not all of these type of authors or scientists can do these conclusions. So
we had a very good team.
Yeah. Do you have any questions?
Congratulations.
Thank you.
I have a question regarding your second topic. Do you know what was the main etiology of ALF? Because it affects the clinical signs, symptoms, and the prognosis of ALF. So what was the main etiology?
So it's very difficult to say because we know as much as the trialists or the clinical investigators are reporting. The question that I can more confidently answer is what kind of liver failure they were not. So they were not chronic alcohol-related hepatitis. They were not viral hepatitis, and we wanted to exclude these patients from the meta-analysis because we wanted to have a patient population that is very closely resembling those patients who are developing a liver injury as part of a multi-organ dysfunction syndrome that is currently acutely developing in the ICU. There are some drug-related acute liver failures, but I think only 2 articles had this. There are no acute hepatitis, viral acute hepatitis patients. So we really did our best with our eligibility protocol, our selection protocol, to make sure that these patients really resemble this kind of multi-organ dysfunction syndrome clinical picture. Sorry? Please use the mic.
So viral infections and drug-induced ALF are the most common ones. Okay, thank you.
Congratulations.
Thank you.
A little bit on my background. I'm from a liver transplant unit, and we see those patients at our ICU also. We are internal medicine based ICU, but because we are also the liver transplant center, all the patients gravitate to our ICU floor. So it's very important to hear this type of distilled informations. I would like to ask you 2 things generally. First is how these results of yours translate to your current approach to the pre-resection patient. If you discuss that if you are already able to discuss that, what you found with your surgeons before the decision making about the surgery or not, because those indications might or might not be treated by resection only. So that's my first part. And the second part is, have you tackled the domain of regeneration? Because some say that liver failure is actually the failure of regeneration. And those questions about if adsorption or plasmapheresis or whatever, some consider that only the bridge to the regeneration. Do you think the method will help the biology of regeneration, or do you think it's only the plain bridge between my own powers of regeneration? Thank you.
I really like these 2 questions, because these are the kind of things that we discuss internally day after day as we were writing the manuscript. So the first about the clinical implication of my results for pre-resection patients. Now, it is my honest opinion that we conducted these studies as part of a intention or a motivation to have standardized, protocolized holistic medical therapies where every patient is receiving the best care that we are currently aware of. This is the idea, because everything is for the patient. Now, when we are talking about preoperative administration of glucocorticoids, the whole question came from the enhanced recovery after surgery protocols for liver surgeries. What I would say is that in these protocols, there are nearly 40 recommendations with varying levels of evidence and varying grades of recommendation. I think there are many recommendations in this protocol that have very strong evidence behind it and very strong recommendation behind it. What I would like to do is go to my surgeon co-workers and say, first and foremost, do these steps of the ERAS protocol, because we know they work. First, do that. Then we can talk about glucocorticoids. And the second question about the regeneration and the underlying idea of what is causing liver to spiral down. During the systematic search for this paper, I came across many studies, most of them from China, which were actually trying to answer this question by administering stem cells to the liver. They were thinking that if we administer pluripotent stem cells to the liver, this should help with the regeneration of liver, and therefore we should see fewer adverse events or clinical consequences that are associated with liver failure. Now, of course, this study, these two studies that we have conducted now, are not answering that question. But as a personal note, I think this is a very interesting question, that it should be taken seriously, and we should actually be trying to understand what are those pathophysiological mechanisms that cause the liver to have these consequences on everything else. Currently, the only way I can answer this question is with a theoretical assumption. Given our knowledge of liver pathology, if we help liver regeneration, we should be seeing our patients get better faster. Yes, sure, theoretically, yes, but it has to be tested.
Is there any other questions from the audience? Okay.
So congrats, Jenner. It was a really nice presentation. I have just a few statistical questions after you've answered medical ones. So my first one is, these figures are really nice. I just didn't pay attention that you only have 7 or 8 patients, whatever. But you've conducted, I believe with Tamás, 6 Wilcoxon rank-sum tests.
Yes.
And this way you've increased the chance of finding false positive results. Did you consider any kind of p-value adjustments?
Yes, we did 2, let's say, safety checks. One was to implement this Hartung-Knapp adjustment to make sure that the results are going to be at least more similar to what we would see in a real world where we have many unknown variables. And the second is we inputted multiple different levels of correlation coefficients, and we were trying to detect if we have separate, different assumptions about the relationship between the patients and the result, how would the end result change? We also put our continuous correlation inputs into the supplementary material of this publication, just to make sure that the statisticians are convinced that we really did our best to avoid p-phishing, to avoid reporting data that is artificially in favor of the intervention. But actually, when we input several different levels of correlation coefficients, we did not see anything change. So what I would argue is that what we are seeing here is not trickery or deception on our part. It's simply the data reported in the literature as it is, adjusted to the best of our ability.
Thank you. My other question would be related to your first article, where you said you had 11 RCTs. And why did you choose odds instead of risk for the postoperative stuff?
So again, when we are doing a systematic review, our main idea, our main objective is to help the readers make clinical decisions. And of course, we can sit down here and discuss whether odds ratio or risk ratio is more appropriate day after day, and this is chicken or the egg. So we rather went to a pragmatic direction, and we said, listen, odds ratios were the typical measurement of outcome in this domain. The trialists are using it, the meta-analyses are using it, and the protocol is referring to odds ratio. Let's not confuse our readers. Let's stick with odds ratio. This was just a pragmatic strategy.
Yeah, that's completely fair. And my last question would be, you mentioned some labor parameters where the poor reporting, due to the poor reporting, you could not do a meta-analysis.
Yes.
And do you know about a statistical approach that would just simply check how many are significant, how many are not? So these are in
Yes.
Not meta-analysis, but in basic science, these are called the omnibus tests. But do you know about some relatives of this in meta-analysis?
Yes, actually, I would have loved to report these laboratory outcomes and the results in an albatross plot. I think an albatross plot, I wish I had an example of an albatross plot, but it's very elegant, it's very beautiful, it's very easy to understand. You can immediately see where the tendency is. The only problem was that I learned about albatross plots 2 years after I finished this paper.
I see. Thank you.
Okay, so one last question, just because, yeah, therefore I'm saying.
Okay, one, I have to choose one. We love, yes, yes.
You can choose one.
Great. Our views on NICE is very different with Benza. Actually, I find these box plots with those lines very poor. I mean, sorry. What if? Okay, one question. Either both statistical and clinical. What if I say that I see that some of the patients actually hadn't made any progress, maybe they didn't need the hemadsorption, and I would consider the proportion of patients getting better instead of these coerced, median comparisons? Sorry, I see that some of the patients didn't make any progress in their levels. Why?
I mean, because this is life. Sometimes interventions are not effective in the way that you can assume,
Still, you chose to compare the distribution of those 7 numbers. Why?
Because we only had 7 numbers.
Okay, but you could go with proportions of patients getting better.
I mean, out of 7 patients or 8 patients or 10 patients, this is just something we never thought about, because this is already admittedly a very weak result, a very weak evidence. So again, it's pragmatism. Our main idea was to try to answer the questions of the readers. And if I'm trying to tell a surgeon that this is the statistical method that I implemented, and these are the adjustments that I made, I lose the audience. They are not interested in this. And for the statisticians, we already very honestly and transparently reported, both in the methods section of the paper and in the discussion of the paper, this is very, very weak evidence.
Okay, thank you.
Yeah, I have a note on the question. The note is that students, please ask questions. I mean, we are here because we need, even if time is going on, but this is important because this is a scientific debate, and then you, in the meanwhile, you learn actually scientific debate. So most of the fellows are year 1 students. They have never seen this, so this is the main reason actually they are so, maybe the early morning too. The question is here, actually, is that, I mean, these are preliminary in many ways, 2 small sample size, but still. I mean, in my eyes, there is a tendency that you get a decrease only if the pre-treatment value was high. While the pre-treatment values was low, so close to normal, I would assume, then you don't see a kind of change.
Yeah.
So therefore, I mean, this answers partly, maybe, I mean, this may be a comment rather than a question, but you can actually...
No, but I mean that's actually a very good point, and this is one of the cardinal differences, the categorical differences between interventional studies and observational studies. In an interventional study, we would be able to assume what if scenarios. What if the baseline was like this? What if the course was like this? What if these patients are not resembling these patients? How do I handle that? But in an observational study, as these were, in an observational studies, all we can do is to report exactly what we are seeing at that time, at that moment, at that space. And this is the nature of interventions. Sometimes they are really not doing anything.
Thank you, and I think it would be also quite a good concluding remark as you said that, and it's true also for this answer, that these meta-analysis and this kind of data can be such accurate as the original data. So if the creatinine or any of the lab values are not high before, then after, it cannot be justifying factors as well. So I think the main point of this whole presentation and also the debate, just the original data and the outcome of the meta-analysis has to be in parallel. Yeah. So we are not criticizing this data, we are just criticizing the original data. So I suggest just to stay here. We are going out in a maximum 10 minutes. We are coming back and then we will have the results. So, okay.
Thank you.
I'd kindly ask everybody to stand up because it's a real honor for us and for you, Kenner, and also for your mentor. And I just want to open up the decision of the committee that we were all very impressed of your results, or also your presentation, also your ability of discussion and openness and way of thinking. So we are congratulating you because your defense is 100%. Everybody gave you a 5. Also those ones who doesn't have the right to vote, they said as well it was very, very good. So congratulations to you. And thank you very much. You can sit down. I just want to say a couple of words, like closing remarks. I think it's, as I mentioned that at the beginning, it's my first time as well, not only yours, to take part in defense from meta-analysis papers, and I'm a basic scientist and a clinical scientist, and for me it's really, to be honest, or as I learned to, my honest opinion is that it's a completely different way of thinking, and it was really impressive how you collected the data. I know, and I hope that everybody knows the importance of your data and your results for future clinical perspectives and everyday guidelines, how important your findings are. And I do want to congratulate your group, because without them, as you said it as well, it couldn't have happened. So first of all, congratulate to your tutor and also the statistical and also the patients and all those ones who have written those articles that you were working. So that's it. I hope that you will have a nice career after that. And I think the way you interpret your data, you don't overinterpret it. It's a very, very rare, how to put it in English, so it's a very rare way of behavior of scientists not to overinterpret your little small baby. You haven't done that. Congratulations on that as well, and congratulations to you on your future career. Thank you very much, and from our side, it's finished.
Thank you very much.
Those ones who wants to congratulate him, just don't hesitate to do it right now.